Welcome. Welcome to the ERA Journal Club. Each e-seminar takes place on the last Thursday of the month at 1700 Central European Time, which is 1600 here in Oxford. We have an e-seminar which picks out a topic from the original research or key review articles in either NDT or CKJ, and the author or authors all introduce their work, and we have at least one expert on the panel. Today it's moderated by myself, Will Herrington, an Oxford-based nephrologist, epidemiologist and trialist. And the discussion after the presentation will be focused, but fairly informal, and we'll encourage live questions. Please do enter them into the chat, and we'll try and answer as many as we can during the seminar. But it's recorded and it's made available on various video platforms. So if you want to listen on repeat, keep an eye out on social media for links. Now, today's topic is the good old aldosterone pathway, which has renewed interest in nephrology following fantastic results from two large finerenone trials. What with SGLT2 inhibitors, nephrology is spoilt for large-scale practice-changing research in the last 4 years, and we need to think about how we implement them, both safely, but mostly importantly, efficiently to maximize the benefits for our patients. And we have all three co-authors of a really comprehensive review of the effects of nonsteroidal and mineralocorticoid receptor antagonists in CKD available to us today. They're all based in the US. The first author is Bryan Lowe. Kevin's from the Einstein Medical Center at the Sidney Kimmel Medical College at Thomas Jefferson's University in Philadelphia. We have Janani Rangaswami, who's attending nephrologist and professor of medicine at George Washington University School of Medicine and Health and Sciences, and Muthiah Vadugunathan is a cardiologist, a trialist at Brigham and Women's Hospital and the Harvard Medical School. So it's a breadth of expertise to the ERA Journal Club today. Welcome to all of the co-authors. Thank you for joining. And if that's not enough to satisfy you, we are also incredibly grateful to Peter Rossing from the University of Copenhagen, who's internationally recognized expert in the field, particularly in relation to diabetes and the aldosterone pathway. So thank you also, Peter, for joining to share your knowledge. So it's a stimulating topic. We've got the world experts available live. Our presentations and discussion will follow. I nearly always ask the presenter why they're interested in the topic, but it's pretty obvious with such important data available. So I'm just going to hand straight over to Kevin to start his presentation.
Thank you very much for having me today and for the opportunity to present our work we did with Dr. Rangaswami and Dr. Vadugunathan. So let me share my slides. So we're going to discuss for the journal club, the nonsteroidal MRAs and cardiorenal outcomes in patients with CKD. I have no disclosures. So the outline of the talk will deal with a brief background on cardiac-kidney interactions, the essential differences on steroidal and nonsteroidal MRAs, the mechanism for benefit. Then we'll examine the data on efficacy in the phase 2, phase 3 trials and the future directions in this space. In 1836, Dr. Richard Bright first described CKD among patients with shrunken kidneys and albuminuria, but he also did autopsy reports and actually showed concomitant cardiac remodeling and left ventricular hypertrophy. But from 1836, we've come a long way in our understanding of heart-kidney interactions in this figure from the scientific statement from Dr. Rangaswami et al. We've seen here that hemodynamics, neurohormonal dysregulation, and the inflammatory pathway play a central role in the dysfunction of the kidney, which in turn can lead to another dysfunction to the heart as well. And in order to address all those pathophysiologic mechanisms, we have in our armamentarium lots of GDMT therapies. Classically, spironolactone is one of the pillars for heart failure. And because of the landmark trials such as RALS and emphasis heart failure, showing survival benefit among these patients on top of RAS inhibition use, and for emphasis also on beta blocker use. However, we see here that as the EGFR drops in this analysis by Patel et al. With the Guidelines Registry, the use of RAS inhibition and MRAs actually also dipped down. And even it's actually more prominent with eGFRs 30 and below. And in the same analysis, ironically, these patients with the low GFRs are actually the ones at highest risk for, such as this example, it's inpatient mortality, with highest odds of inpatient mortality as the eGFR levels drop. And this is consistent across the spectrum of ejection fraction. And this phenomenon might actually be related to renalism, which was coined by Dr. Chertow in 2004, which is simply the systematic exclusion of potentially beneficial therapies in patients with CKD, either with the perception of it's not going to help them, or they're scared about the side effects in relation to CKD. Our group also did a systematic review of trials for heart failure reduced ejection fraction in the past 10 years. And we've seen here that MRA use has stagnated, and RAS inhibition use slightly dipped down in the past 10 years. This is in the setting of more inclusion of patients with advanced CKD in the trials that we're already seeing right now. In relation to the kidney side this time, because we've discussed the heart failure background and MRAs, we also look at the effects of MRAs and the kidneys. This meta-analysis by Chung et al. Shows that steroidal MRAs together with RAS inhibition actually helped a bit with the intermediate endpoints, albuminuria, eGFR slope, and systolic blood pressure reduction. However, this was understandably accompanied by an increase in hyperkalemia and acute kidney injury, as well as the known side effects for the gynecomastia from spironolactone. Again, no long-term follow-up data was given, no hard clinical outcomes were reported. There is a continuous drive to use MRA inhibition on top of RAS inhibition because there's a phenomenon that we can call aldosterone breakthrough. And it happens when people with RAS inhibition initially have their serum aldosterone reduced, but after a couple of weeks, in about 30 to 40% of patients, the serum aldosterone returns to pre-treatment levels. And we know that aldosterone has harmful downstream effects such as fibrosis. So there's always this quest to come up with an agent that can improve cardiac and kidney outcomes, but also to minimize side effects such as hyperkalemia and acute kidney injury. And thus, we have this non-steroidal MRAs. To discuss some differences between steroidal and non-steroidal MRAs, for this figure, representative molecule here is finerenone. Finerenone acts as a bulky antagonist, and it keeps the mineralocorticoid receptor in an active conformational state so that it can't be stimulated further. Another good thing about this is it also acts as an inverse agonist where it prevents cofactor recruitment regardless of the presence or absence of aldosterone. And this can have some downstream benefits later on with the fibrosis as well. In this table, we compare non-steroidal and steroidal MRAs. Steroidal MRAs are lipophilic, they cross the blood-brain barrier. It can help modulate blood pressure through hypothalamic mechanisms. A key difference here is that non-steroidal MRAs are equally distributed in the heart and the kidney, as opposed to spironolactone, which is undetectable in the heart. This can have some implications later on because it can have the potential to give cardiac benefit, but at the same time, kind of minimize the renal effects in equinatriuretic doses. And as mentioned in the previous slide, it acts as a bulky antagonist and an inverse agonist. We also kind of briefly mentioned here exacsarenone, which is actually one of the other non-steroidal MRAs only approved in Japan so far. It has also shown like maybe a utility in resistant hypertension, also reduction in urine albumin creatinine ratio. Non-steroidal MRAs finerenone also has higher affinity and selectivity, which leads to that less rates of gynecomastia as compared to spironolactone. And another key element to remember here is that finerenone has a very short half-life, and compared to spironolactone, which lasts for a long time, this is because spironolactone has lots of metabolites such as canrenone, and these metabolites actually exert still residual mineralocorticoid effects, and that can lead to downstream effects such as better blood pressure reduction with spironolactone, but also higher rates of hyperkalemia with spironolactone as well. We now go to the mechanisms for benefit. We emphasize in this figure that the central role of inflammation, fibrosis, and endothelial dysfunction in the pathophysiology of heart and kidney dysfunction. Finerenone reduces the inflammatory cell infiltration by upregulating IL-4, which is an anti-inflammatory cytokine. It increases nitric oxide secretion, also reduces the free radicals because of upregulating superoxide dismutase. And if we know that we prevent endothelial dysfunction, then we also prevent albuminuria, which is a surrogate of this. And albuminuria, in turn, is also a marker of kidney disease progression and poor cardiovascular outcomes in the future. And lastly, finerenone also exerts a direct anti-fibrotic effect, preventing recruitment of fibroblasts and myofibroblasts. It also reduces the gene expression of these fibrotic genes, plasminogen activator inhibitor and tenascin X, and eventually would lead to less cardiac and kidney dysfunction. On a side note, because of the reduced hyperkalemia rates, there is an opportunity to combine with other GDMT use to further improve cardiac and kidney outcomes. Now we go to more detail to the phase 2 trials, which were done for dose finding and efficacy. It's the main ARTS group of studies. The first ARTS trial, the investigated doses and in comparison open label to spironolactone. But also notable findings here is that in the ARTS-HF trial, there was a 30% decline in the cardiac biomarker NT-proBNP, but it was also in this trial where they found a significant reduction in the composite clinical cardiovascular endpoint. And that is despite not being powered for this endpoint. And in the ARTS-DN trial, where they investigated on CKD, there was a reduction in urine albumin creatinine ratio, but not much increase in hyperkalemia events, almost an average of 2%. Because of the promising phase 2 trials, understandably, phase 3 trials were done. And there's two main sister trials which enrolled patients simultaneously with overlapping inclusion criteria. All of these patients had diabetes, all of these patients had CKD, but there are some fundamental differences. For Figaro, on the right-hand side, Figaro was predominantly enriched to look for the cardiovascular composite outcome. As a result, they enrolled patients, more with cardiovascular history, about 40 to 50%. With known cardiovascular disease. For Fidelio on the left-hand side, this was the trial powered or enriched for the primary kidney composite outcome. So they enrolled more patients with more advanced CKD, lower eGFRs, and higher albuminuria rates. One thing we have to remember is that they required a run-in period where they had to maximize RAS inhibition use. Looking closely at the trial populations, there was a significantly lower amount of patients with a Black population. While this is not entirely unique to this trial, a lot of cardiovascular and kidney trials also have under enrollment of Black patients. This certainly needs to change in the future. As we mentioned before, Figaro trial was powered for cardiovascular events. So understandably, a lot of patients with known cardiovascular events or disease. Fidelio was powered for kidney outcomes, and they definitely enrolled the patients with almost 20 points lower mean eGFR. And lastly, later on, as it might come up with our discussions, the SGLT2 inhibitor use, background use, was actually low in both trials, less than 10%. And we can come visit that later again when we talked about co-utilization of medications. Looking at Fidelio DKD, again, this is the trial driven predominantly for kidney outcomes. The primary composite outcome was significant with a hazard ratio of 0.82, but also the secondary pre-specified cardiovascular endpoint was also significant at hazard ratio of 0.76. Looking at the forest plot closely, we see here they use both two outcomes for kidneys, a decreased GFR of 40% from baseline, which was significant. And they also used a more robust outcome, 57% eGFR from baseline. Now, this corresponds to a almost doubling serum creatinine, which was the cutoff they used before in the landmark trials in the renal study, losartan, and in the irbesartan CKD studies from before. So both are significantly reduction in kidney outcomes. Looking closely at the hyperkalemia side effects, serious hyperkalemia of more than 6.0, less than 2%, although remains double compared to placebo. However, we should interpret this again in the context that these patients are more advanced CKD and on RAS inhibition on top of that. Now, in the Figaro trial, again, this is the trial powered for more cardiovascular outcomes. The primary composite outcome was significant with hazard ratio of 0.87, while all the other secondary outcomes were not significant except for hospitalization for heart failures, which was at a hazard ratio of 0.71. This might actually be the one driving the main primary outcome as well. This KDIGO heat map simply shows us where we plotted the phase 2 and phase 3 trials, that the trials on non-steroidal MRAs actually enrolled a high-risk patient population like advanced CKD, significant albuminuria. And finally, in the fidelity pooled analysis, where they combined both phase 3 trials, again, to reiterate, type 2 diabetes and CKD, eGFR above 25, and potassium had to be less than 4.8, already on maximally tolerated RAS inhibition. And they notably, of course, didn't include heart failure with reduced ejection fraction because these patients would qualify at baseline for MRAs. And despite not including heart failure patients, they all still find a significant difference with the reduction in heart failure hospitalizations, reduction in the composite cardiovascular and kidney outcomes, and all of these on top of a fewer rates of hyperkalemia discontinuations. Again, the forest plot emphasizing very strong signal for heart failure hospitalizations reduction and the GFR reductions as well. So future directions, we've talked about earlier about the combination of SGLT2 inhibitors. In this meta-analysis by Brendan Nguyen et al., they found that in the cardiovascular outcome trials, there was a lower rate of hyperkalemia, hazard rate of 0.84, favoring SGLT2 inhibition. So this has some potential utility, perhaps combining SGLT2s with MRAs or RAS inhibitors. There was also a sub-analysis of the Paradigm trial where they showed that sacubitril valsartan combined with MRAs had a lesser rates of hyperkalemia compared to enalapril alone. In this trial, the Provenza et al. Rotate trial, they combined the eplerenone and dapagliflozin, and it actually showed an additive drop in urine albumin creatinine ratio, almost reaching 50%. And this comes at a significantly lower rate of hyperkalemia as well. Looking at future directions, we have some exciting trials in the pipeline. Fine Arts HF will investigate finerenone in patients with EF more than 40%. The Confidence trial, the Miracle trial, they investigate concomitant SGLT2 use with finerenone and urine albumin creatinine ratio. Fine CKD will investigate finerenone in patients with non-diabetic CKD. And again, to reiterate, we're actually dealing with complex patient populations, patients with cardio, kidney, metabolic disease. So one good approach here is a multidisciplinary care approach, harmonizing the practice guidelines, interdisciplinary education, instituting risk mitigation strategies and self-management programs, all to improve outcomes in these patients. So conclusion, there has been decades unmet need for use of MRAs, and specifically in CKD. But the data for the phase 3 trials for finerenone seems to be high-level evidence. And we have now pillars of kidney disease therapies, RAS inhibition, SGLT2 inhibitors, non-steroidal MRAs, but perhaps GLP-1 trials that are coming out soon. We'll see. And again, now we go to the next phase. We have all these medications available. How do we get it to our patients who need them the most? So we need equitable access and implementation science. And that's the end of my talk.
Thank you, Kevin. That was a brilliant tour of some randomized data as well as the background behind the mechanisms. I really enjoyed it. It's very exciting to see a new treatment. It's so interesting to see it. The old pathway, 1999 was a Rails result, and we're still generating important randomized evidence. And at last, the kidney community is benefiting from these large trials. So thank you for summarizing it for us all. There's a lot of questions we can ask, a lot of questions people might be having about, the results, but also implementation. And the first question I think most people are going to ask is, when can they get hold of these drugs? When can they start to use them? There's always a delay between clear results in trials and ability to use them. In the UK, we've just had the NICE guidance published. We have indications for use in people with type 2 diabetes. They have to be treated on with a RAS inhibitor, and they also need to be treated with an SGLT2 inhibitor and have albuminuria. So I'm wondering what it is around the rest of the world, whether or not there's an obligation to have them on an SGLT2 inhibitor, whether or not finerenone is considered, third line treatment for diabetic kidney disease. So Peter, maybe you could start with the Danish experience at the moment.
Yeah, thanks. In the Danish setting, we have had finerenone reimbursed for approximately half a year, and it has the same limitation or condition that you need to be on SGLT2 and RAS blockade if tolerated, and GFR range 25 to 60. So it's the indication was based on the Fidelio trial, and it's also in the guidelines of the Endocrine Society that after use with RAS blockade and SGLT2, you can implement it as the reimbursement rule says.
Interesting. Okay, that's great. So the Danish and the UK can get hold of it. What about in the US? Muthiah, what about you? You're already using this in your cardiology clinics widely, presumably.
Yeah, so finerenone received regulatory authorization by the FDA in summer of 2021, and so it's been at least available for prescribing for a considerable amount of time. Again, the initial labeling was based on Fidelio, and then there was some additional modifications to the label, particularly in terms of safety, with the addition of the Figaro and Fidelity pooled analyses. In terms of, we probably have one of the messiest markets in terms of actually implementation and access. And there's great heterogeneity based on the individual payer that ultimately will support coverage. Some are requiring similar stepped approaches with background therapy necessitating SGLT2 inhibitors, but some are not based on so it is still remains quite variable. In most of our health systems, though, as we've seen with many other cardiorenal metabolic therapies, the implementation of this therapy has been relatively slow to modest. And I will just one other note in terms of a different setting, certain areas of the world, there is easier access. For instance, in India, there's quite cheap availability of finerenone. And so there has been relatively rapid implementation of finerenone. So clearly this is I'm glad you led with this question, because this is the critical element that I think holds many of us from optimizing care in practice.
Yes, as trialists, we really hope that when you have a clear result, you can start to make a difference to practice rapidly. So Janani, what about the Veteran Affairs hospitals? Are they the same? And what are your thoughts about implementation?
Thanks, Will. I agree with all the other panelists that this is literally the most important question to lead the discussion with. And to reiterate what Muthu just said, the market here is messy. There's really no great framework for rapid uptake and equitable implementation. The VA system is an exception to that rule where equitable and rapid access is possible. That was seen with the SGLT2 inhibitor, approval in the VA system as well. And there is a pathway for finerenone use. And just as Peter alluded to, it is necessitated on the backdrop of ROS inhibition as well as SGLT2 inhibitions. There could be several considerations for that. It could be the cost. It could be the fact that we do need to ensure that patients are on appropriate foundational therapies and we're not skipping steps and going straight to a bright new shiny medicine as well, because there is significant national underutilization of these therapies. But to echo Eugene Braunwald's musings on this question, even in systems such as the VA where access is not the issue, uptake is still slow. And there was a recent big analysis on SGLT2 inhibitor use in the VA system showing relatively low rates of uptake. So again, lots of work to be done in that space in terms of examining all these barriers to implementation.
And maybe to add to that, I think one way of getting around or maybe supporting implementation is to have quality metrics that measure if you have kidney disease or if you have heart failure, that you're actually treated with these new disease-modifying drugs. And we have implemented that from this year, and whether it will have a positive impact, we need to see in the future.
And I just wondered if anyone had any thoughts about the requirement to be on an SGLT2 inhibitor. If you look at the finerenone trials, I think it's about 93% of people weren't. So the majority of the data demonstrating efficacy and safety, in fact, is based on people not on SGLT2 inhibitors. Any thoughts about why that was a requirement for a lot of the payers? Anyone, any thoughts?
Yeah, I can speak to the Danish story, and I think the reason was that SGLT2 inhibitors were already in the guidelines being recommended. They were on the market in different versions for a long time, so it was a more familiar drug, and therefore finerenone was seen as a kind of new add-on. But as you say, that was not how trials were done. It was these 7% that were on SGLT2 inhibitors. On the other hand, you could say it might be a benefit that if you start with an SGLT2 inhibitor, as we heard from Kevin, then you'll have less risk for hyperkalemia, and therefore starting with SGLT2 and then adding finerenone could actually be a good combination where you have less side effects and more benefits.
No, I think it's excellent. And there are certain types of patients who haven't been tested in the finerenone trials. I was wondering if I could probe you a bit on those. I was wondering about people with, because I was struck by the how many times albuminuria was mentioned in your talk, Kevin. I was struck by the fact there isn't people with the really low levels of albuminuria, and also people with really low levels of kidney function, perhaps more typical for the patients coming to nephrology clinics. It looked like very much a sort of a progressing population within the diabetes clinics. So is there any uncertainty about benefits and risks in that group? Do you think there's space for more trials in people with diabetes? Maybe Janani, what you thought of that? Sorry.
I agree. I do think there's always room, especially for de novo initiation in that CKD4 range eGFR. It's such a fundamental question, such an understudied group. Fortunately, the SGLT2 inhibition data have broken into that space. And when you look at pre-specified post-hoc data, it looks reassuring both from safety and there is efficacy. And, you have also, been a pioneer in leading trials in that space, including that patient population. I do think it is an understudied area with finerenone at this time. If you see a patient, a lot of the times delayed referrals to nephrology, access to nephrology care, specialty care can be very variable. And a lot of the times we end up seeing patients in that GFR range. And then the question is there now incremental benefit to adding one more therapy? And what are we actually getting? And perhaps even if not so much on the kidney side, would we potentially see a heart failure benefit, which is such a big competing risk in that patient population, premature death and the cardiovascular. So if I were interested, I would honestly be more interested in attenuating the cardiovascular risk, even in that advanced CKD group.
That's very motivating to think there is more space for trial evidence that we can look really further down. Okay, and so the other group of populations that I always have a personal pang of guilt about is people with type 1 diabetes, because they've been excluded. They did brilliantly and got involved in the RAS inhibitor trials at the very beginning. And unfortunately, the side effects with SGLT2 inhibitors made them more difficult to study in the large, simple trials which we've had. And so what about people with type 1 diabetes? Is there, and I think, Peter, this is your area of expertise. Do you think we should be using these drugs? What's out there in terms of the future, in terms of potential data?
Yeah, I think it's an excellent question that we haven't had new data since 1993 in the type 1 space, and we really need, because the prognosis of people with type 1 diabetes and kidney disease is just as serious as in type 2. And as you said, SGLT2 inhibitors, those complicated GLP-1 receptor agonists were tried for glucose control, but not really for cardiovascular or kidney outcomes. And finerenone is an obvious choice, and I hope that we can soon have a trial in the type 1 area with finerenone and testing it for kidney benefits. In Denmark, we actually got support for a trial which will be a large outcome trial in type 1 diabetes, where we'll try to use some of the new drugs from the type 2 space in the type 1 patients. So it will include both finerenone and SGLT2 and GLP-1 based on a risk algorithm and based on clinical characteristics. If you're obese or atherosclerotic, you'll get GLP-1. If you have kidney disease, finerenone, and if you have some signs of heart failure, so you'll get SGLT2. And in that sense, we hope to see if these agents that seems to work independent of glucose on kidney and heart could also benefit type 1. I'm sure they can, but we just need the evidence before we can recommend it.
Thank you, Peter. There's one more question, and I wanted to ask Muthu this question, if that's okay. It's a question we received before the seminar from one of our attendees, which is about use in elderly patients. And we get this question quite a bit with SGLT2 inhibitors now. So we actually recruit large numbers of people who were elderly, but also, the heart failure trials. I mean, people with recently hospitalized with worsening of heart failure were particularly high risk and quite a frail group. And there was very clear benefits. In fact, they are the group which benefit the most from SGLT2 inhibitors. Could you say anything about, finerenone in those groups, or in fact the other types of MRA that you use as a cardiologist? Are you confident using them in the frailer, older patients?
Yeah, so it's a wonderful question, especially in the frail heart failure patient. We typically use doses that are of either non-steroidal or steroidal MRAs in heart failure and chronic kidney disease that have actually fairly limited hemodynamic effects in our high-risk populations. This may seem a surprise compared with kind of our experience, for instance, with resistant hypertension populations, but in our in these high-risk target populations, the between-arm differences are fairly modest in terms of blood pressure lowering, and the rates of clinically significant hypotension are very infrequent. And so it's actually a very well-tolerated therapy, even in an older, frail patient. Furthermore, these patients, as mentioned, were actually fairly well represented in many of the pivotal trials, and including in noted that worsening heart failure population. The recently completed, in terms of enrollment, Fine Arts heart failure trial, which was a trial of over 6,000 individuals with heart failure and a left ventricular ejection fraction above 40%, enrolled a very substantial fraction above the age of 80 years old. And so I think we'll have very compelling evidence, hopefully, of not only the efficacy estimates of understanding how we can avert cardiorenal risk in that population, but also the safety. And I think that piece of the puzzle is important to add confidence to our implementation and practice.
Thank you, Muthu. I mean, that's very interesting indeed. I mean, I was struck by your table, Kevin. The half-life of finerenone is so short. There may be more modest effects on blood pressure. There does seem to be also, in terms of safety, less effect on acute kidney injury. We saw with dual RAS blockade trials, the increased risk of acute kidney injury. Do you think the half-life and the effect on blood pressure with finerenone, which is mild and that might be contributing to the apparently better safety profile in terms of acute kidney injury?
Yeah. So actually, based on experience as well, it's really hard to start these patients on a lot of RAS inhibition, GDMT all together. And I think that's where the space is going, starting, especially for patients with heart failure, starting GDMTs simultaneously. So with the lower drop in blood pressure, that can potentially drive more clinicians to maybe get these therapies all on board at the same time.
You're talking about polypills, are you? Okay, so I mean, I'm beginning to believe there is a significant difference between, the non-steroidal and steroidal MRAs in terms of some of the subtler details, which might actually be impacting on safety. But the obvious issue with these drugs is hyperkalemia. We see that, it's almost a universal effect of these drugs, and it did result in some patients having to stop treatment in the finerenone trials, although remarkably small numbers actually. I was wondering about the generalizability of the results. So the FDA license, I think, is limits use to people with potassium of 5 and below. The trialing excluded people with potassiums above 4.8. I wondered how much confidence there might be, particularly within the cardiology community, first of all, Muthiah, about using them at higher levels. Nephrologists are a bit more blasé about hyperkalemia till it hits 6. We don't notice it until then, but I wondered what your thoughts and experiences are within your heart failure population.
Yeah, so I think, Will, that's a critical question, and of course, hyperkalemia has long been the kind of Achilles heel of MR inhibition, and I think the trials themselves were well suited to guide implementation in the sense that the first potassium measurement initiation MRA, and that's very different from regulatory labeling that is offered, for instance, for the steroidal MRAs that are currently in practice. And that is that speaks to, I think, the tolerability and the ability to broadly implement this therapy across settings. I think that'll also ease the ability to initiate finerenone even in higher risk settings early after hospitalization, for instance, where access to a laboratory measurement or clinical encounter might be more challenging in the very near term. So I think that with the better safety profile, I think clinicians are going to embrace this to a larger degree in terms of being more comfortable to not only initiate the drug, but monitor it on a perhaps more relaxed timeline.
Very nice. Kevin, there's a question from our chat, which I think relates directly to this, which is, why do we think finerenone is less likely to cause hyperkalemia if that is actually true? Is there, you had a nice, figure, and you've thought about the mechanisms. Could you explain again why you think it might be the case?
So I think a lot of factors come into play. First is the radionuclide distribution from our previous studies from before, that they said there was more equal distribution in the hearts and the kidneys. So you potentially get the cardiac benefit and in the equinatriuretic doses from before compared to spironolactone and eplerenone. The other thing is also having that not having a long half-life, because the traditional MRAs also have like the metabolites that remain active for hours. And when you have that mineralocorticoid effect active for hours, then you also have that blood pressure lowering effect at the same time, hyperkalemia as well, active for hours.
And we've got a very short question here from one of the people before they joined. But I mean, Janani, I was wondering if I could ask you this one. Could we just use spironolactone? I guess your point about implementation and equity of implementation would be much easier if the drug was almost at no cost and free.
That's so interesting, Will, you bring that up, because that suddenly became the burning question in nephrology after the finerenone data came out, and they woke up to the fact that we had all these years. We had nice post hoc data from the MRA space in heart failure. We have a lot of experience in nephrologists or frontline to get referrals for an enriched group of patients for treatment-resistant hypertension, which is where everybody rushes to use this. Somehow it never occurred that aldosterone breakthrough was a key mechanism to be addressed in CKD progression, and we could have just used it with the collective experience we had in the first place, which is a drug available even to an uninsured patient for $4 a month, which is spironolactone. Granted that the sexual side effects are not small, and we have to be sensitive to, the higher potential rates for hyperkalemia, but we have a lot of mitigation strategies. So in some way, we should stop making excuses. We have 2 FDA-approved newer oral anti-hyperkalemic agents. We have SGLT2 inhibitors that can be used in combination, and they're safe and effective. So I think there's going to be some, interest in comparing head-to-head non-steroidal, steroidal MRA. And I don't even know that it would be ethical to have a placebo arm in that setting. And that's another evolving ethical question. What do you even keep changing as what the new backdrop therapy should be? But I think a head-to-head comparison will hopefully nudge people a little more, whether you pick one or the other, pick something, rather than just debate, should it be steroidal versus non-steroidal?
I think we've been pragmatic in nephrology for many years, haven't we? Okay. But did you want to add anything? I had a specific question for you as well in a second. But,
I'm happy to defer. The only thing I'll add is that, and Kevin had shared this, I think there was a meaningful head-to-head comparison in the phase 2 program of the ARTS-HF program of steroidal versus non-steroidal MRAs. This was finerenone versus eplerenone in over 1,000 people with worsening heart failure and chronic kidney disease. And there, while natriuretic peptide lowering was relatively comparable between arms, there was this exploratory endpoint that was favorable in terms of clinical outcomes. And we have now many programs underway in heart failure with reserved ejection fraction, evaluating both steroidal and non-steroidal MRAs against placebo. So I think we're going to learn more about these therapies individually in different spaces of chronic kidney disease and heart failure. And hopefully the data, when pieced together, will help guide specific selection of therapy.
Yeah. I remember TopCat and being a bit disappointed, obviously, that with the TopCat result in people with preserved ejection fraction heart failure, but also it was quite striking that spironolactone isn't in the cardiac tissues or doesn't distribute there according to Kevin's table. Do you think that finerenone and equal distribution might be a key factor in potentially affecting some of the pathways in HFpEF? Do you think there's a really good chance that we've missed the opportunity by the fact that we haven't got these MRAs into the right tissue?
Yeah, I think that's certainly theoretically possible. I'm hopeful, and I'm biased. I'm one of the investigators of the finerenone and heart failure trial, ARTS-HF. But I will say that spironolactone itself is being studied in additional dedicated trials of SPIRIT-HF and SPIRIT. They're named very similarly, but distinct trials. So we'll have 3 total large-scale cardiovascular outcomes trials in this space, all reporting in the next 1 to 2 years. So a wealth of information. Many of us believed TopCat was at least provided a signal for hope of MR inhibition, even at higher ejection fractions. But there's complexity, of course, in the interpretation of that trial. So I'm glad to see that there's now going to be more definitive evidence in this space.
You can see also that the key driver of the cardiovascular benefit in the Figaro trial was a reduction in hospitalization for heart failure. So I share your optimism in this space. Although, I mean, we don't know the ejection fraction, but either they had no heart failure at baseline or at least not advanced heart failure.
It's a really good chance, isn't there, Peter, that these benefit preserved ejection fraction heart failure. And then there's a particular expertise of yours, which of course is aldosterone synthase inhibition, a slightly different mechanism. I wondered if you might talk briefly about how that pathway or that drug mechanism is slightly different to the non-steroidal MRAs, why it may have additional benefits or not, and what's being done in terms of studies in CKD at the moment.
Yeah, you can say the difference would of course be that there are effects of aldosterone that are independent of the mineralocorticoid receptor that you are blocking with finerenone or the steroidal MRAs. So there are other pathways which clinical implications I'm not sure we really know, but we will learn about that with these agents. And you can see we saw recently good effects on blood pressure with such agents, and in CKD they are being investigated and in combination with or compared to SGLT2 inhibition, and I think this later this year we will see data on how that pans out. So will it provide similar changes in albuminuria or something different? And potentially it could be different. Side effects could also be different, with less hyperkalemia potentially. So it's going to be very interesting to watch that space, I think.
There's Baxdrostat, which was reported in the New England Journal of Medicine in November in a resistant hypertension population, which had very impressive effects on blood pressure, at least from my perspective, seeing the difference between placebo, and then there is a drug being developed in CKD. With results, I hope, by the end of this year, maybe the ASN, I don't know. So what about people without diabetes, Peter? I know it's not necessarily, but do you think that will be informative?
Yeah, I think that as we heard, if you talk about finerenone and non-diabetic kidney disease, the FIND CKD study is ongoing. It's with a slope endpoint, and why shouldn't it be efficient also there? Of course, you can say before the SGLT2 inhibitor trials, the non-diabetic kidney disease was a bit messy, where many potential attempts to stop progression of kidney disease failed. With SGLT2 inhibitors, it seems that you can stop progression completely the same extent as in diabetes. I would expect that with finerenone, we see the same benefit in non-diabetic CKD, and soon we will get the answer, I think.
Yep, and I wanted to advertise that Kevin didn't mention it, but he did show on his slide the ACHIEVE trial. I'm pretty sure that's referring to the Canadian coordinated trial of spironolactone versus placebo in dialysis patients. So, this old drug is really beginning to boil up and create a real interest within nephrology. I hope the results will be available. That you said 2023. I'm not sure if it's going to be that soon, but if it is, I suspect it's going to be a little while longer, but perhaps not much longer. So yes, the aldosterone pathway is definitely up front alongside the sodium glucose co-transporter pathway and our good old angiotensin pathway. So fantastic times for nephrology. Muthu, you've been bathing in sort of glory of randomized trials within cardiology for years. I'm so glad we're beginning to catch up, and we're having this puzzle of too many questions to answer and not enough trials to do it in. I wanted to really sort of draw a bit to a close now our discussions. I mean, it's clear that these drugs work in the groups of patients who they've been studied. We've now got a choice of 3 drugs to have to start to implement. We know what the side effects are. We know how to potentially work around them. It's now just time to hand over to the community to implement. And then it's over to ourselves, I think, as trialists and epidemiologists, to then extend to the next set of questions, which I think are really clear. So I'm really grateful to you all for sharing your knowledge and expertise today. Kevin, thank you so much for presenting in such a daunting panel of experts. Your review article was really excellent. I have to say there is another review article, I think, illustrating the interest in this from the ERA's Eureka M working group, which has also looked at MRAs, and that was available in NDT as well from January. So please do go to the NDT website and download both papers when they're available, because you can become an expert in MRA like our panel. And please also, at the end of this seminar, I do ask you to stay on just for a couple of minutes and answer our survey. We think of ways to improve the journal club, and your feedback is really essential for that to happen. And then do put the last Thursday of the month into your diary for the next ERA Journal Club. Jennifer Lees and Kate Stevens will return next time, they'll be discussing an area close to their hearts, which is representation of women within clinical trials. I'll certainly be interested in clearly a key question, particularly when we're designing our new trials in the aldosterone pathway. So for now, it's goodbye from the panel.